Although you may expect that the stones in gallstones is purely illustrative, in actual fact, stones not too dissimilar from those you find out and about can actually form in the digestive tract, though they are given a slightly more scientific name than that, calculi. A calculus is a solid mass of material primarily consisting of crystallized mineral salts, such as calcium. Over time, these crystals build up and form stone-like lumps in organs, ducts, or passages such as the urinary tract, throat, gallbladder, or bile ducts like the common bile duct and pancreatic duct. Development of calculi is called lithiasis, with the stones being referred to as liths depending on the area of the body where they are found. Before we talk about the specific types of stones that can form in the body, there are a few general features that encompass all of the stones spoken about. The causes of lithiasis can be genetic or environmental, and specifically they can either be from an excess of minerals or certain conditions that result in their formation. There are two ways that stones can cause disease and damage, which gives rise to a few general symptoms. The first of these is irritation of the surrounding tissue and subsequent pain and inflammation that results. Stones can also block the normal flow through an organ or duct, which prevents it from performing its function and aids infection. Now, let's look at the variety of different calculi that can form in the body. Stones which develop in the urinary system are called urinary calculi, which are usually either kidney stones, nephroliths, or bladder stones, cystoliths. These stones are relatively common and develop in the urinary tract, which includes the kidneys, bladder, ureters, and urethra. Stones smaller than 5 mm usually have an 80% chance of passing in the urine, though those any larger may cause blockages of the ureter and only have a 20% chance of passage. There are 4 types of kidney stones, each of which are classified depending on their composition and have distinct properties. The first of these are calcium stones. 2 calcium salts can cause stones to form, the most common of which is calcium oxalate. These stones account for around 80% of kidney stones, and because they are radio-opaque as opposed to radiolucent, they can be seen on X-ray and CT scans. They are a black or dark brown colour, and acidic urine is an example of a good indicator of oxalate stone formation. The calcium in these stones can come from 2 sources: the gut, where excess calcium is absorbed from the diet into the blood, or the bones. The second component of these stones, oxalate, is a dianion that is produced in plants through the incomplete oxidation of carbohydrates. It forms crystals with cations in the body, such as calcium 2+ and iron 2+, which are excreted in the urine. Oxalate is produced naturally in the liver, although foods high in oxalate include black tea, rhubarbs, herbs, nuts, chocolate, and berries. Apart from an oxalate-rich diet, there are multiple other risk factors for these stones. These include obesity and hypercalciuria, which refers to elevated calcium levels in the urine. Hypercalcemia also increases risk, referring to high calcium levels in the blood. This is usually caused by hyperparathyroidism, cancer, or in rare cases, some inflammatory conditions. Hypercalcemia usually goes undetected without unrelated blood work and causes psychiatric symptoms along with muscle, joint, or bone issues. Hyperparathyroidism is when the parathyroid glands excessively produce parathyroid hormone, which is supposed to regulate serum calcium concentration in the bones, kidney, and intestine. The causes of this hormone imbalance can either be from within, primary, or outside, secondary, the glands, though it is most likely due to benign parathyroid adenoma. Moreover, dietary calcium or vitamin D supplements can also induce these stones to form. Hyperoxaluria describes elevated oxalate levels in the urine, either caused by a genetic defect, primary, or an alternative condition such as Crohn's disease, a type of inflammatory bowel disease. The final risk factor is having had surgery to resect part of the colon, as this reduces urine volume, thus concentrating the salts it contains. The other type of calcium salt is calcium phosphate. These stones account for around 5 to 10% of kidney stones and are radiopaque and dirty white in colour. Phosphate stones prosper in alkaline urine and in the presence of Proteus bacteria. Phosphates are a family of minerals found in tooth enamel and bones, and food and drinks containing phosphoric acid are more likely to cause phosphate stones, such as fizzy drinks. The next category of stones is uric acid stones. These stones account for around 5 to 10% of kidney stones, and although they are a yellow or reddish-brown colour, they are radiolucent. As the name suggests, the circumstances they are found in include acidic urine. Uric acid is a product of purine metabolism, purines being a group of 2 ringed chemicals containing hydrogen and nitrogen, which are found in most food and drinks, although they are mainly concentrated in organ meats, seafood, and alcoholic beverages. Other examples of purines are adenine and guanine, components of DNA, along with caffeine. Uric acid is a standard component of the urine which forms urate ions and salts, and around 250 to 750 milligrams is excreted in the urine per day. The average concentration in the blood is between 25 to 80 milligrams per litre for men and 15 to 60 milligrams per litre for women. Risk factors include obesity, hyperuricasuria, referring to elevated uric acid levels in the urine, and high uric acid levels in the blood, known as hyperuricemia. Hyperuricemia can be caused by a multitude of factors, including genetics, insulin resistance, hypertension, hypothyroidism, kidney disease, diuretics, and diet. It also results in gout, a form of inflammatory arthritis, which may further increase the risk of kidney stones. Similar to calcium stones, inflammatory bowel disease and colon resection can increase the risk of developing stones. The third type of kidney stones is struvite stones. These consist of the mineral magnesium ammonium phosphate and account for around 10 to 15% of kidney stones. They are radio-opaque and dirty white in colour and are sometimes called infection stones as they can occur alongside UTIs and other infections of the kidneys and ureters. Ammonia-producing pathogens and increased magnesium excretion can cause these crystals to form, as the ammonium and magnesium ions are primary components of struvite. Moreover, bacteria can hydrolyze urea into ammonium and carbon dioxide using the enzyme urease, as well as increase pH to more alkaline conditions, which encourages struvite crystal precipitation. The primary risk factor for these stones is an infection, and factors which increase the risk of UTIs, such as spinal cord injury, sexual intercourse, and urinary tract blockages or abnormalities. Metabolic disorders such as hypercalciuria, hyperparathyroidism, and gout can also encourage formation, though unlike other urinary calculi, they are not influenced by diet. The final and rarest type of kidney stones is cystine stones. These only account for around 1 to 2% of kidney stones and are radio-opaque and pink or yellow in colour. Cystine, spelled C-Y-S-T-I-N-E, is descended from the amino acid cysteine, spelled C-Y-S-T-E-I-N-E, although cystine is the oxidized dimer form, meaning it contains two identical cysteine monomers. In this way, cystine has two crucial functions, being the site of redox reactions and offering structural support for proteins. Dietary sources include meat, eggs, and dairy products, and it is also found naturally in the body in the hair and skin. Cystine buildup is only caused by two rare genetic conditions which affect its metabolism in the body, thus making it extremely uncommon. These conditions are cystinuria, an autosomal recessive disease characterized by elevated cystine levels in the urine, and cystinosis, a rare autosomal recessive disorder characterized by abnormal accumulation of free cystine in lysosomes. General risk factors that increase the likelihood of all of these stones forming include dehydration, which increases the concentration of all of these minerals and is hence a leading risk factor. Particular conditions that result in stone formation involve the reduction of inhibitors such as magnesium and citrate, or a congenital disorder called medullary sponge kidney. This disorder is characterized by cyst formation in the kidney tubules, inhibiting outward urine flow and promoting UTIs and stones. In terms of the symptoms of kidney stones, these only occur when the stone is large enough to cause damage and arise from blockage of the ureters or movement within the kidney. A person with such stones may experience severe, sharp pain in the lower back or abdomen below the ribs. This pain may radiate to the groin and is called renal colic. Renal colic is caused by peristaltic contractions by the ureter in an attempt to pass the stone. The patient may also experience vomiting, blood in the urine, foul-smelling urine, or painful urination. These may also result from complications which, albeit rare, can occur if the stone goes undetected for long enough. The main complication of kidney stones is hydronephrosis, which refers to a blockage in the urinary tract. As a result of this, urine may build up in the kidneys, which may make them more prone to urinary tract infections, sepsis, or even obstructive nephropathy, which leads to kidney failure. However, this will very likely resolve reasonably soon after the stone is passed, and the chance of any long-term issues is minute. The other significant type of stones that most people have heard of are those which develop in the gallbladder and bile ducts. These are gallstones, also called choleliths, and common bile duct stones known as cholecystectomy. Similar to kidney stones, 80% of people with choleliths are asymptomatic, as symptoms only present when the gallstone moves and blocks the common bile duct. This duct flows from the liver to the duodenum, also containing branches to the gallbladder and pancreas. The gallbladder stores and concentrates bile, a green fluid produced by the liver that is responsible for emulsifying lipids and neutralizing stomach acid in the small intestine. It is composed of roughly 98% water, 0.7% bile salts, 0.2% bilirubin, and 0.5% cholesterol and other fats. The two primary pigments of hepatic bile are bilirubin, which is a yellow color, and biliverdin, bilirubin's green oxidized form, which, when mixed, results in the brown color of feces. These components become important when looking at what makes up gallstones. The constituent of bile that accounts for the vast majority of stones is cholesterol, coming in at 80%. Cholesterol stones are usually a yellow or green colour and only count as cholesterol stones if they contain 80% or more cholesterol by weight. In the bile, this cholesterol plays a role in the structure of cell membranes, being a precursor for steroid hormones, bile acid and vitamin D, and for cell signalling. In this way, the cholesterol is oxidized to form bile salts. In terms of where exactly it comes from, 80% of cholesterol is manufactured in the liver and intestines, and dietary cholesterol is contained within all animal-based foods, especially in red meat, eggs, fat, and offal. Usually, the body is very good at regulating levels, as increased dietary cholesterol results in lower endogenous production and vice versa, though sometimes imbalances can occur. Cholesterol stones form when the balance between cholesterol and bile salts in bile is inadequate, usually as a result of dietary intake or failed regulatory mechanisms. One other risk factor for cholesterol stones includes lower melatonin levels. This is because melatonin inhibits cholesterol secretion, encourages cholesterol to form bile salts, and is an antioxidant which reduces free radical formation. Melatonin production decreases with age, so this can also have an impact. Moreover, imbalances in the levels of bile and liver proteins that promote or inhibit cholesterol crystallization can also encourage stone formation. Another risk factor that may be more common is increased estrogen and other hormone levels, which raise cholesterol levels and decrease gallbladder motility, meaning the cholesterol remains stuck in the main body of the gallbladder. Pigments are another component of bile that can form stones. Pigment stones are composed of bilirubin or biliary calcium salts, which gives them a brown or black colour. They only count as pigment stones if they contain less than 20% cholesterol. In terms of what bilirubin actually does, it is a secondary byproduct of the catabolism of hemoglobin to its precursor, heme. This is important in removing aged or abnormal red blood cells as waste products. It is described as secondary as heme catabolism produces biliverdin, which undergoes reduction by the enzyme biliverdin reductase. Metabolism, meaning the series of life-sustaining chemical reactions within the body, can be categorized into catabolism, involving breaking down, and anabolism, or synthesis. Catabolism, such as that of hemoglobin, can be used either to construct new polymers or further break down monomers to release energy. There are also two types of bilirubin, depending on whether it is bound to other molecules. In the blood, for example, bilirubin is unconjugated, meaning it is free and attached to the transporter protein albumin. In the liver, however, bilirubin is conjugated as it is combined with glucuronic acid and is strongly concentrated to be later excreted. Remember how pigment stones can be either brown or black. Brown stones may be indicative of infection, usually with gram-negative bacteria. In contrast, black stones are typically caused by red blood cell problems like liver disease and hemolysis, in which these cells rupture. There is only really one significant risk factor for bile stones, which is known as hyperbilirubinemia. This refers to elevated bilirubin levels in the blood, potentially caused by excess hemolysis, Gilbert syndrome, which affects bilirubin metabolism, certain pharmaceutical and chemotherapeutic drugs, hepatitis, biliary stricture, common bile duct stones, and cirrhosis. The third and final type of gallstones is mixed gallstones. These contain between 20 to 80% cholesterol, the other constituents commonly including calcium carbonate, phosphates, and bile pigments. Given that they often contain calcium, they are usually radio-opaque and are usually a result of biliary tract infection. This is because injured hepatocytes and bacteria release the complex carbohydrate enzyme beta-glucuronidase, which results in more unconjugated bilirubin in bile. General risk factors that increase the likelihood of all types of gallstones include low gallbladder motility. This is because it increases the concentration of bile contents and may be caused by excessive resistance to bile flow in the cystic duct, which connects the gallbladder to the common hepatic duct. You may be also more at risk if you have a family history of the disease, are female, Caucasian, obese, or over 40. Metabolic disorders like diabetes can also increase risk. The symptoms of gallstones are usually a direct result of complications, as most gallstones are asymptomatic themselves. The most common telltale sign of gallstones is biliary colic. Colic refers to sudden pain caused by the reflexive smooth muscle contractions which attempt to relieve an obstruction in a tube within the body. Biliary colic occurs when the cystic or common bile duct is temporarily blocked by a gallstone, causing cholecystectomy, in which the flow of bile into the duodenum ceases. The symptoms of this include intermittent pain in the upper right quadrant, which may radiate to the back, nausea, vomiting, bloating, or belching. Cholecystitis is also a possibility, which refers to inflammation of the gallbladder. Cholecystitis is usually preceded by biliary colic and is caused by a blockage of the cystic duct. Symptoms include severe, constant upper right quadrant pain, which may radiate to the right shoulder tip, nausea, vomiting, mild jaundice, and Murphy's sign. Murphy's sign refers to gallbladder tenderness on inspiration, as it comes into contact with the examiner's hand. Cholangitis is when there is infection and inflammation of the bile duct, and the symptoms are grouped together into Charcot's cholangitis triad. These three symptoms are abdominal pain in the upper right quadrant, fever, and jaundice. Jaundice has already been mentioned a few times, but what actually causes this symptom? If a gallstone blocks the common bile duct, it causes bile to back up, resulting in cholestasis and obstructive jaundice. Jaundice occurs as the excess bilirubin in the bile is absorbed into the bloodstream, causing a yellowish pigmentation of the skin and eyes. If the source of the high bilirubin levels in the blood is unconjugated, i.e. the kind typically found in the blood, then this is usually caused by excess hemolysis or bruising, whilst conjugated bilirubin suggests problems along the biliary tract, such as cirrhosis, infections, cancer, or obstructions. The symptoms of cholestasis and obstructive jaundice include itching, pale stool, and dark urine. Another complication of gallstones is pancreatitis, which refers to infection and inflammation of the pancreas. The symptoms of pancreatitis include severe, constant upper left quadrant pain, which may radiate to the back and is exacerbated by eating. Nausea and vomiting may also be present. While kidney stones and gallstones are relatively familiar to most people, you may be surprised to hear that some stones form in more unusual areas of the body, such as the nasal passage. When they are found here, they are called rhinoliths. The nasal cavity where these stones develop is the hollow space behind the nose, divided into two fossae, which are connected to each of the nostrils. Rhinoliths are extremely rare and commonly confused with dried nasal mucus, which means that they are usually asymptomatic and diagnosed incidentally upon a routine examination. They are most commonly seen in young children and have a much simpler composition than other types of calculi. Rhinoliths form around masses in the nasal passage, which can either be exogenous foreign bodies or endogenous blood clots, bone fragments, and secretions. Over time, calcium, iron, and magnesium salts are deposited around the mass until it continues to grow and become a large irregular obstruction. There aren't really any physical risk factors for rhinoliths, though they may be confused with other potential causes, or the foreign bodies in the nose may go unnoticed. As mineral deposition increases and the calculus grows, unilateral nasal obstruction and foul-smelling nasal discharge may be observed. Again, this discharge may be confused with rhinitis or sinusitis. Rhinoliths may also cause epistaxis or nasal bleeding as the surrounding mucosa becomes ulcerated. The main complication is pressure necrosis of the nasal septum caused by ischemia to that area, although this is rarely seen. Another more unique type of stones refers to those which form in the gastrointestinal tract, known as enteroliths. These can start anywhere in the gastrointestinal system and can grow to be enormous. Enteroliths are uncommon and rarely harmful, though they may eventually need to be removed if complications arise. They are also mostly radiolucent, so ultrasound is used for diagnosis rather than an X-ray. They form in a similar way to rhinoliths around a nidus, or small foreign object, though it can also be confused with gallstones and gastroliths due to their diverse chemical composition. Enteroliths typically form within a diverticulum, which is an area within a hollow structure which protrudes out of its main body. They may also form around a bezoar, which is an indigestible foreign object within the gastrointestinal system. Enteroliths have similar risk factors to rhinoliths and biliary gallstones. In terms of the symptoms of enteroliths, due to the large diameter of the bowels, when complications do arise, they are usually rather serious. One of these includes bowel obstruction, in which the intestines become blocked, preventing food being digested from moving through the GI tract. Bowel obstruction can be caused by multiple things, including adhesions, hernias, inflammation, tumours, volvulus, or intussusception. It may also occur after the enterolith is expelled from the diverticulum and into the lumen of the bowel. The symptoms of this include abdominal pain, vomiting, and bloating, and it is typically diagnosed with an abdominal CT scan. Along with bowel obstruction, ileus is another potential complication of enteroliths. This refers to the loss of the intestine's ability to propel products of digestion through the bowel via peristalsis. The symptoms of ileus are abdominal pain, constipation, abdominal distension, and vomiting. One of the most severe complications of enteroliths is bowel perforation. This occurs when a hole forms in the wall of the bowel, usually within the diverticulum where the enterolith begins. This allows the intestinal contents to spill into the abdominal cavity, causing infection and potential sepsis. Symptoms involve sudden onset abdominal pain, abdominal tenderness, nausea, and vomiting, with or without blood. Kidney stones, gallstones, rhinoliths, and enteroliths are just 4 of a whole host of stones that can form in the body. Other structures stones can form in include the stomach, known as gastric calculi or gastroliths, the salivary glands, where they are called salivary calculi or sialoliths, the tonsils, known as tonsillar calculi or tonsilloliths, and rarely the veins, where they are referred to as venous calculi or phleboliths. Given that there are so many different types of stones, each of which can be composed of various substances, diagnosis can sometimes be difficult, especially when the presenting symptoms are quite general. Diagnosis may initially be suggested based on the patient's history and symptoms. These may be accompanied by other conditions which could act as indicators, and dietary or other lifestyle factors may be involved. A physical examination will also be useful, as different tests can distinguish between different types and locations of stones, such as in Murphy's sign for acute cholecystitis. There may also be urine or blood tests, as along with the base diagnosis, these can also detect accompanying complications. For example, they can describe mineral levels, urine pH, and infections, as different stones prefer different conditions. Along with the previously mentioned diagnostic tests, medical imaging can be especially useful, especially if surgery appears to be a likelihood. Ultrasound is the most common due to the wide range of stones it can view, though X-ray and CT provide high-resolution images of radio-opaque calculi. Endoscopy may also be used, in which a camera on the end of a thin, long tube is inserted into the body to view a particular organ or structure. This may be preferred to scans, as it provides a close-up view of the calculus and can be used for all accessible structures. Even though most stones are asymptomatic and therefore don't require treatment, some stones may require non-surgical intervention, surgical intervention, or both. The preferred approach to a stone diagnosis is called watchful waiting, which is where doctors closely observe the patient's condition but only intervene with treatment or therapy when symptoms appear or change. When these symptoms do present, the first port of call is usually pain management through non-steroidal anti-inflammatory drugs, NSAIDs, or opioids. The patient will also be given medications and antibiotics to target the underlying causes in an attempt to spontaneously pass the stone, such as alpha blockers. Another non-surgical treatment method used when drugs don't prove useful is lithotripsy. This involves the physical destruction of stones so that they can be passed without the need for surgical intervention. Intracorporeal lithotripsy includes the insertion of a minimally invasive probe to crush the calculus endoscopically. On the other hand, extracorporeal shockwave therapy, ESWT, uses a highly focused and intense acoustic pulse to fragment calculi, with the patient usually sedated or anesthetized to avoid discomfort. However, the most common treatment of calculi is surgery, as, despite the expensive cost of anesthesia, surgeons, and equipment, surgical treatments have been highly refined to minimize time under anesthesia along with complications. More accessible stones can be retrieved with simple instruments and without the need for any anesthesia at all. There are two general surgical procedures to remove stones, these being lithotomy or resection. Lithotomy is an invasive procedure to remove stones embedded in the abdominal organs, while resection involves the complete surgical removal of the affected organ, or at least a part of it. The first-line treatment for gallstones is to remove the gallbladder laparoscopically, as the risk of complications is extremely small and the procedure can be performed in 1 to 2 hours. The gallbladder is an expendable organ, as bile can flow directly into the small intestine without any issues if the gallbladder has been removed. Calculi prevention isn't something that most people consciously try to do, rather a case of being generally healthy by maintaining proper nutrition through diet and exercise. The one thing though that significantly helps to reduce the chance of getting stones is increased fluid intake so that more than 2 liters of urine is passed daily to dilute minerals in the blood, bile, and urine. Despite this, kidney and gallstones are one of the most common everyday conditions there are, with 10 to 20% of Americans developing them at some point in their lives. Their prevalence in developed and developing countries continues to rise as quality of life improves and obesity rates soar. It is no surprise that gallbladder removal is the 8th most common surgical procedure in the US. However, this also means that the techniques to resolve calculi are incredibly effective and well established, forming the bread and butter of a trainee or general surgeon's day-to-day cases.